Is general practice in crisis? There's so many challenges coming our way at the moment in terms of resources for staff, issues with supplies, including blood bottles, which we're going to be talking about, as well as the various other challenges facing general practice right now. So, we are going to postulate the question: is general practice in crisis? What can we do about it? And is it going to change? Let's take in hands your primary care and learning. Hey, GP learners, you've got myself and Andy talking today about whether or not general practice is in crisis. How are we doing there, Andy?
Yeah, I'm good. I'm enjoying things over here in my part of Nottingham, and looking forward to the discussion. I noticed when you posted the trailer for the session for today, and that we were going to be discussing this. The first thing someone responded with was like an asteroid hitting the
Mhm.
Earth with a GIF. So if that's representative of the mood out there, it could be pretty bleak.
Well, we're going to find out. I'm going to be talking about various different aspects of what's currently going on in general practice. One of the key things that is happening as we speak is, unfortunately, the UK is going through a blood bottle crisis, which is having a huge impact in terms of what the future for general practice, the healthcare system, pretty much everything we're doing may impact things. So we're going to talk about that, as well as we're going to go over an article written by the incoming president of the RCGP, Dr. Clare Gerada, in terms of her views, as well as various other aspects in terms of basically what's going on in general practice. If you are joining us live, you are more than welcome to jump in and put some comments and stuff in, and we're starting to see some coming through, so definitely add more as we go along. We'll come to those shortly. But let's start off with from the beginning, shall we then, Andy? Are we in crisis? What do you think? What do other people think?
So I think we should walk through some of the evidence and some of the opinion as we go. I'm going to save my verdicts until the end of the
Mhm.
consultation, as I think any good GP should, and not jump to conclusions. I'm really interested to see what the people out there watching and commenting have to say, because I've got a feeling that whilst I think everywhere things are pretty bleak and under pressure, I've got a feeling there are
Mhm.
probably pockets of absolute crisis, and there are probably pockets of what Theresa May used to call the jams, the just about managings, who are
Mhm.
actually not too bad. So it's going to be really interesting to see what the picture's like up and down the country. How about yourself? What's your initial reaction to the question?
I think we're at a point where people talk about crisis. Is it that acute thing, that chronic thing? And many people have predicted the end of the NHS for a while. Are we getting closer towards it? I think, yeah, it feels that way. We're in the middle of summer, which is meant to be the quietest part of the year, and yet it's probably one of the most chaotic and challenging. I'm currently just finishing 2 weeks of leave, and despite that, I've had to dial in from home to help out in the practice because it's been that much of a problem, trying to make sure that patients are being dealt with safely and effectively. If that isn't a crisis where people are having to help out from being on holiday, I don't know what is. But hey, we're going to talk more about that, aren't we?
Yeah.
Mm. So let's get into it, shall we? So we're talking first of all. There's been an overview article that was written by Dr. Claire Gerada. So we're going to bring that up on screen. We will put the links to this in the show notes and the description. So definitely check those out and stuff. But it's a fairly recent review that talks about Dr. Gerada's perspective of what's happening, and particularly her, as you've phrased it, her prescription for change. Talk us through it, Andy.
Yeah, so it's an article in BJGP, and it's sort of an editorial article. So these are Claire's opinions reflecting on her long years of service in the NHS, in general practice, and with the Royal College of General Practitioners and various other roles that she's held.
Hmm.
She's currently the director of practitioner health within NHS England. So that's particularly looking at the health and well-being of the workforce and the medical workforce, and has been instrumental in setting up the GP practitioner health service, and and other useful interventions like that. So she should have a finger on the pulse of how GPs are feeling and coping, and she's been involved in that space for a bit of time. So I think she's well positioned to comment on the prospects for general practice at this point in time.
Hmm.
Um, yeah, she really sort of covers a number of headings and areas which are both her analysis of the problem and areas where she thinks we should focus solutions on. So that's what I would call her sort of prescription for change. What did you make of the article, Gandhi, or do you want to just sort of work through and talk to her points? I think it's a good article, and it provides a good framework for beginning to look at the problem. Although
Hmm.
there's a few areas which she has chosen not to address, which I think we can address in the podcast.
Yeah, so I think talking about the points she has talked about, and then we can obviously go through the parts that haven't been covered. I mean, it's pretty much split up into about, I think, 7 sections, if I remember rightly.
Yeah, and I don't think we need to labour them because we've got a lot of material to talk about ourselves later.
Mhm,
So, I mean, the first thing she says is we need more generalists, and by that she doesn't just mean more GPs, although obviously that would be really, really helpful. In fact, I'm just going to reflect on something. A funny story, Gandhi. So, one of my partners, who's been a partner for quite a long time, and
mhm,
hadn't given their details to any locum agencies as far as they were aware, or at least not recently. Got a text message. I'm sure we've all been getting these text messages saying, "Come and work here, £1,000 a day." You know, locum. You think, "Gosh, I don't have time to do anything." Um,
mhm.
they got a text about a locum session in our practice. So it was one of the partners in our practice,
Okay.
sat there seeing patients. Got a text about a locum session in our practice. Can they do a locum session? I just thought, wow, that is like, problem within a problem within a problem. That's
Absolutely.
crazy. But anyway, yeah. So Claire talks about needing more generalists. What she also means, so she means more GPs, but she's also talking about actually more generalist physicians in the hospital as
Yep.
well, and is sort of lamenting the fact that really we used to refer to a medical speciality, and they used to take ownership of the patient, not just this
Mhm,
particular symptom that they're referred with, and follow them through to a diagnosis and treatment plan. And
mhm,
invariably, what we get these days, because of how subspecialized hospital physicians are, often they don't have the specific issue that you've referred with. Therefore, they bounce that back to general practice, and there's a lot of pinging and toing and throwing, and that leaves us a lot of
mhm.
resources. So she's really like more specialists to take hold um, of the patients really. Would that help, Andy?
Well, I think it's an important point to discuss. So at the moment, when many GPs refer a patient into a secondary care clinic, we'll often refer them based on the local pathways that we have, and there's a lot more of the whole concept of pre-refer work that's being done before patients can be referred nowadays. So you and I both know this. When we refer a patient, we have to do potentially blood tests, further investigations, that kind of stuff before we can refer. They go to the specialist centre, and they always look at them, generally speaking, with a view of excluding particular conditions. So, for example, I might refer a patient to a gastro team, query they're having bowel symptoms and want to make sure it's nothing more serious or sinister. And they'll be investigated to rule out things like bowel cancer, IBD, and that's about it. And then they're discharged, but there's not always a management plan about managing the patient's symptoms and the reason they've actually presented itself. It's sent back to us to then figure out what to do with that patient. Now, I'll be clear, this is not a commentary on secondary care clinicians, because I think often they want to do more and try and help the patient, but the system is now designed to rule out patients having particular conditions and not necessarily look at how patients are coping with the symptoms that they're having or the problems that they're having. And is that something where I think Dr. Gerada is trying to focus on, that we need people to actually look at the patient in completeness, looking at the symptoms and the problems they're having and figure out how to help the patient with those issues, not just saying it's not cancer, it's not IBD, it's not X, so therefore discharge and go to somewhere else kind of thing. That's my personal view. I don't know what you think of it in that respect, but
Yeah, I think she's identifying it as another source of work and gap in care, really.
Mhm,
That this stuff used to, she's been in the healthcare system for 30 years, and she's reflecting that people in hospital used to be more generalist, take ownership of the patient, and and manage that symptom and that person. Whereas now that is now done largely in general practice, and it didn't
mhm,
used to be done entirely in general practice. So she's saying that's a source of more issues. Just to highlight, by the way, we talked a lot about demand and increasing demand and increasing complexity, and the increasing age and complexity and
mhm,
comorbidities that patients have. So I think we just said we'll have to take that as read almost for today. We all know these arguments. We may make them again later, but that's all acknowledged. You're sort of focusing more on the specifics that might lead to solutions, because
mhm,
it's a triumph really that people are living longer, so that they get, they're able to live longer, and that means people will experience more illness, unfortunately. And in some ways, that can be seen as a good thing potentially.
mhm.
Anyway, so she talked about generalists. Variation on a theme, talking about we need more intermediate teams,
Yep.
and this again is about that space between the hospital and general practice, and that actually if more, if the expectation is that more of these complex comorbid patients are going to be managed in the community, what needs to move is secondary care resources that would have managed them in secondary care out into the community, rather than just expecting the existing
Mhm.
inflexible, can't, you can't scale up quickly, rather than expecting that existing community primary care workforce to manage those patients. You're saying it just doesn't work, and actually more
Mhm.
intermediate teams and intermediate services sitting at that junction would be good for the sustainability of general practice, and also much more positive for those patients who, in some instances, aren't getting as much care and support as they would need.
Mhm.
So,
It's
I mean,
an interesting prospect though, because I think we have seen some development of those kind of services. So I guess I'm going to give a commentary on local things, and I don't know if your experience is the same with this, Andy. But for example, we have a primary care cardiac service, cardiology service, and they are designed to help patients with particular cardiology-based conditions as kind of like an outreach. One of those is types of heart failure. But if you're a patient with not that particular type of heart failure, they won't help out, but then the secondary care clinics won't help out either because they say that they're not, designed to help with those particular symptoms, and then we are sometimes stuck dealing with patients with symptoms due to heart failure, but not being able to access specialist advice in terms of how to manage them when they become more complex and stuff, and I don't know if you've had that kind of experience, but it's a frustration in terms of how do we then determine what's best for the patient and further plans when they get to those points where they're more complicated.
yeah, increasingly, community and secondary care services have quite tight inclusion criteria for the types
Mhm,
of patients that they will see and will deal with. And, they're afraid of being overwhelmed by the numbers,
mhm,
just like everyone else is, and I suspect if they were better funded themselves, better resourced,
mhm.
then, the inclusion criteria could be expanded. Perhaps they can be expanded anyway, and they should take their share of the very heavy workload. It's easy to start to think like that as well, isn't it? And just think, well,
Mhm,
we're doing all the heavy lifting of what's left over. Why are these people allowed to be so selective when we are not?
mhm.
That's protective for their services, but what about our service, which is really, really struggling?
I think that's
So
fine for particular specialist services. I think there's a difference between the routine kind of healthcare that obviously general practice is designed and capable of providing versus the more complex care for patients with really complex needs as well. I think that's the part where particularly the intermediate concept of having better outreach and more broader outreach may provide better care for our patients. And maybe that's something that things like the ICSs and all that kind of new structure stuff that we were told would never happen again is happening, may help with, but we shall see, shall we not?
yeah, there are individual examples,
Mhm.
and many of them, of people who work in these services who are absolutely fantastic. I just
True.
want to say that, who communicate really well with general practice and suggest a plan when they contact you, and
Yeah.
do a really good job. So I just want to make sure that we say that as well.
Mhm.
Yeah, Clare is really going after this interface with secondary care in this article, actually,
Mhm.
because she also talks about, um, we need to stop the expansion of GPs' roles. Oh no, the next bit was, yeah, we're not community house officers. That's something we often say to each other as well, isn't it?
True.
Gandhi, when people say that phrase, because
Yeah.
people might not be familiar if they're not too familiar with how UK healthcare is structured, what do they mean?
So this is generally speaking of a secondary care clinician. So this is not necessarily a consultant. This can be those working in their clinics, nurse practitioners, other allied health professionals working within those clinics, and sometimes even other types of professionals. With which often starts with the phrase GP to do X, Y, and Z. And that can often give the impression that it's the GP's responsible, the practice's responsibility to then take over the stuff that the clinic wants or should have done potentially themselves. Now, this is a tricky area. Let's be clear on this because there are certain aspects that general practice should, and importantly, should always be doing. But there is a line, and then there's also the tone that comes with those kind of requests. Particularly, my personal view, if ever it's something that a clinician asks and then wants us to send them the results of, for example, or the implications of those actions back to them, to be honest, they should have done it themselves. Simply put, that should not be sent to the GP practice to do. If those services aren't there within that system, then that's either a poorly thought out process or it's a work dump. And that's how many GPs feel when we get these kind of instructions. It's a dumping of the workload. and obviously the resources to help do that workload do not come with it. Um, so that would be my needle on the matter. I don't know what your view is
Mm.
on that particular part.
Yeah, please refer to X, Y, and Z place.
Mm.
When they're discharged from hospital, for example, those sorts of things really irk me because it's obvious that uh, they want it to happen.
Yeah,
They just haven't written the letter
yeah.
themselves. And then you have to start from the beginning and see the patient, take all of the history. It's something
Mhm,
that could be done much more quickly in general practice. So that's one example that particularly irks me and does increase the GP workload. And it's probably a reflection on increasing workload in secondary care that they feel they don't have time to do
absolutely.
these things either. I mean, maybe we should have said, is the NHS in crisis? And maybe we'll expand it in the future and talk about
Mhm,
that from our perspective in primary care. Um, she talks about this is an interesting point, Gandhi. I'm interested to know what you think about that. So, for a long time, there's been this phrase that GPs are best placed to do this, and we've often encouraged ourselves and each other to take on new roles because the community is the best place to do lots of things. It's close to the
mhm,
patient, particularly if they're not acutely unwell. A lot of things are best managed in the community. We're well placed within the community. We have access to blood tests. We can review patients. We can um, uh, order imaging and so forth. Maybe the GPs are best placed to manage all sorts of things rather than occur within hospital clinics, which are difficult to get to. I think we've been encouraging that. And Claire's saying she's guilty of encouraging that in the past. She's sort of
mhm.
fessing up, but saying actually that perhaps needs to stop because the resources are just not following it. What do you think, Gandhi?
I think you've hit the nail on the head. General practice could be a really great place to deal with a lot of the healthcare needs of our population. The problem is that generally speaking, it is not resourced in the way that is effective for that to happen. And unfortunately, though, the view that just because we're closer to the patient in terms of geographical, personal relationships, then that's why we should do everything that comes out for the patient as a result of it. That would absolutely be the case if we were resourced to do so. General practice does 90% of patient contacts in the NHS, but we receive 10% of the NHS funding. We talked about this before. Imagine if that was 20% of the NHS funding, how much more effective could general practice be at doing all this stuff that we're being asked to do, and probably do it a lot better than what's currently happening. But that requires the resources to help fund that. And we're not just talking about money, we're talking about the actual resources to make that happen. So, staffing, processes, systems, those kind of things have a huge implication. And we know we're going to come to those, but absolutely, that's where this whole concept of the role, therefore, well, GPs can do everything, well, we can't. And that's a problem that we're continuing to see as time
Mm.
develops. We're seeing more and more restrictions in terms of what GPs can actually do, but there's still that background perspective of, well, it's GP's role to do everything. We are effectively the risk sink of the healthcare system, and actually, the sink's now broken potentially.
It's blocked. We need a plunger.
Well, I'd say it's bust open, but yeah, different perspective.
Okay, yeah, okay. It's all going everywhere, all across the kitchen floor or the toilet floor.
Yeah.
So yeah, why are appointment times so short? So someone's just flashed a comment up
Mhm.
out there. I'm I struggle with names, so I'm not even going to try. But thank you very much for the comment. Um, it comes to that. Let's skip to that. So it talks about proper job plans. Claire
Mhm.
talks about here, and the thing she goes straight for is the number of patients that GPs are expected to routinely see every day, and that should be capped for safety reasons. And I think that relates to appointment times because if you set that cap, at a lower level that allows more time, that's when you can have more time with patients. If you say 15-minute appointments, but we're still seeing 37 appointments a day, then that's just completely unworkable.
Mhm.
Yeah, Gandhi, why are appointment times too short? We've been asked the question.
I think it's a disparity in terms of what people need versus what is available to have. As you said, if we're having, 30 plus contacts per day, how can you schedule that to work on top of all the other stuff that is required for you to do in terms of the administration, the meetings, the supervision, all the other aspects that come with the running practices, engaging with practices, and that kind of stuff? If you look at the European aspect, they limit to 25 patient contacts a day. I would have that occasionally, most often on most single mornings. If that was to incorporate in a whole day, I've counted it up. I've had 50, 70, I've had 100 patient contacts in a
Mm.
single day. And that is something that is not sustainable. And if every patient was to say, well, I need 15 minutes, 15 minutes times 100 patients, Yeah, that doesn't work, to be honest, you know?
It's a resource and workforce issue, isn't it?
Yeah.
I mean, if there were more GPs, then you could do that.
Yeah.
But there just aren't the GPs to deliver 15-minute appointments and sustain the level of activity, the number of appointments that
Mm,
happen. The
so
maths
I
just
think there are, and
don't
there are
work.
places that are doing that, but they also use other resources to help them do that. So they use other allied roles to help deal with other types of issues. They use technology resources to help with that.
So Gandhi, just to stop you. So
Mm.
these patients are getting 15-minute appointments with their GP. Is that what you're telling me?
There are some places where that happens, yes.
Really? And there's okay, fair enough. No, I can see that.
Mhm.
But like I'm sure the average contact time with a GP for everyone who wants a GP appointment, it
Mhm.
just cannot be 15 minutes. I mean, some people are getting 15-minute appointments, but that means that other people who might want a 15-minute appointment are getting
Agreed.
an electronic consultation,
Yes.
which is not the same thing as universal access to 15-minute appointments. But I understand the point you're
Yeah.
making. Yeah.
No, absolutely
There
agree.
are other
I
ways to
think that
structure it.
I'm not aware of any practice which can say wholeheartedly that every single patient that makes contact has 15 minutes with a GP clinician. Yeah,
Yeah,
agree
yeah,
with that
or
point.
or is able to give 15, is able to give it. Or so, we got a follow up. So who will want to be a GP if you tell them they have only 15 minutes to see a patient? That's mad. Oh gosh, no, they've only got 10 minutes to see a patient, and
Yeah.
often less than that.
Mhm.
And that's to do everything you need to do and conclude that consultation safely. So that the patient feels safe and satisfied, and so that you as a clinician feel that you have managed it safely. So it can be very difficult, and this is why many people believe we are in crisis. Um,
Absolutely.
so let's finish Claire's sort of prescription analysis. Really, pull down your own oxygen mask first. So it's really it's that thing where if you lose pressure in the cabin on the aeroplane,
Mhm.
um, you need to put your oxygen mask on first so that you can then help other people. So it's about people. It's about general practice. Look, it's really a call to arms, really, and saying, okay, right, let's just look at the profession. If we fall over, we can't help people, and that's actually the ultimate reason why we're here. So
Mhm.
so let's make sure we sort ourselves out. So yeah, should we move on to some of the things that we've sort of collected and to add to this discussion?
Absolutely. And just to comment on Pupsius's comment, so we're going to come to some of the positives that still do exist. So not to worry, this is not all doom and gloom, although potentially coloured with rose tinted glasses, shall we say? But yes, Andy, you're talking about other resources that we have access to
Yeah.
and things. So yeah, lead us through it.
Yeah, well, it's an appraisal of the situation, isn't it? So looking around, just in addition to what Claire's saying,
Hmm.
my colleagues look tired. People are telling me that it's never been this bad. Just to add another another dimension to it before we start to get
Hmm.
positive. Um, but let's look at some sort of data. So, I mean, the first thing is um, let's look at the GP. So this is a bit more doom and doom and gloom first. We were going to get more data first.
Hmm.
So Pulse do an average survey. I think we looked briefly at some of the results from this a few episodes ago, but this provides a reflection of how hard people report that they are working in terms of number of contacts per day, what they feel would be safe, how complicated things are. Um, how long their day typically is. And let's just reflect on some of these things and see if you feel this is accurate. But it also just adds to that sense of crisis. 37 average patient contacts a day. Doesn't say how that's defined. Whether
Hmm.
I'm assuming that's a direct telephone or face-to-face contact with patients. That's how that number makes sense to me, and
Yeah.
not all the additional ways we touch patients' lives in terms of reviewing blood results and processing letters and doing other administrative work for them. People feel that 28 would be safe. So, and actually, I think 15 patients in the morning, 15 patients in the afternoon is sort of a classic workload going back
Hmm.
to my training days and before then. That felt like that was appropriate. I think it might actually even be stretching it now, given the increasing complexity of patients over
Yep. And
time.
noting that that's still more than the European average.
Yeah, yeah, yeah. But that's what people are sort of reflecting on. Um, How complex are people? Well, they're fairly and very complex.
Hmm.
Um, People are working an 11-hour day, they're saying, typically, when they're in surgery, when they're doing their job, um, with a lot of clinical time still. and a lot of other work. And do you consider your workload to be at a safe level? So the majority of people, or the plurality of people, saying no with Don't Knows 11. So a minority of people saying that they
Mhm.
don't, that they think it's safe. So that's pretty that's pretty bleak. So
Mhm.
I think we painted the bleak picture. Oh, and the final thing was so this was a really interesting um, piece of work that we came across from the BMA, most recently updated in August this year. So very recently, although I'm
Yep.
not quite sure when the original data collection took place. And there is, we'll have the links in the show notes. There's some great detail of stats going up to 2021 about how work is being done and who it's being done by in general practice. It also reflects on how things have changed over time, but it's a
Mhm.
good snapshot of who's now working in general practice, which I think is really interesting.
Mhm.
And I think these, you've got pharmacists here, so I expect to see some of these bubbles to grow much bigger as
Yep.
primary care networks sort of complete their recruitment and come up to full workforce complement over time. Um, but still, actually, majority GP partners rather than
Mhm.
salaried, which was interesting to see. We've not yet reached a tipping point, despite everything that is said and written about the GP partnership model. Um, but just drilling down, there was a key sentence in here. Yeah. So they were just saying, so there are more GPs in training, there are more GP bodies, but actually, if you take into account how many full-time equivalent days being worked, and actually that the population has increased and the number of people registered with GPs have
Mhm.
increased, the result is now that from in 2015 there were 0.52 full-time equivalent GPs per 1,000 patients in England, and that's now down to 0.46. So I think, regardless of what people tell us, there are fewer GPs to patients. There
Mhm.
are other roles which people will say, but there are fewer GPs. So, oh,
I think
RCGP, you've done a good bit
yeah.
of work. Um, this is mainly looking at the changes in access patterns, how people are accessing their GP. Please learn something from the BMA in terms of data presentation. This is fantastic, and there isn't even a table there. Sorry to have a dig, but if you do good work, give us a
Mm.
table. RCGP,
I think it's
please.
a valid point. You know, the
Yeah,
RCGP have often been commented that their media engagement needs to be a bit more considered, shall we say. I know it's something
yeah,
I've been public calling them out on multiple occasions. Having said that, they have created an action plan for recovery, which is their recent campaign. I think that they're publishing over the past week or so, particularly looking at, again, focusing at engaging with MPs in terms of the changes that need to happen in general practice to make it more sustainable and functional. And you know that's a current campaign that they've been pushing in the past few days in particular. So definitely check out some of the stuff on Twitter and things to help with that. You know, in terms of looking at what the RCGP feels needs to change in order to help with things. I think one of the interesting things you mentioned about that statistic in terms of the whole time equivalence and the number of GPs to population ratio. You know, we're down to what was it, 0.46 per thousand
yes,
patients GPs. You know, compared to 3.5 in other countries. You know, we're talking nearly 7 times more the number of doctors to patients in other countries. And part of
yeah,
the reason we're seeing that reduction is that concept that Clare Gerada mentioned about putting your own oxygen mask on first. You know, I've had a few trainees that have finished working with me this year, and every single one of them has said that, you know, their perspective of full-time working is 3, at the most 4 days a week because it's that intense. And actually, every clinician in our practice works that amount of time as a maximum, particularly the partners. And actually, increasingly, I think we're seeing partners reduce their workload because they just cannot cope with the complexity, the depth, the time. You know, 3 days a week still works out to 60 hours a week for me at the moment. So
yeah.
that's a huge implication in terms of what we're seeing for the future, and how can that balance with patients' perspectives of wanting to still see their GP? It's a question that can't, I think, be answered.
Absolutely. I'm not sure about this 3.5 figure. I think that might be actually total qualified doctors per 1,000 population.
Mhm,
It feels more like other figures I've seen. So it's interesting they threw that in there.
mhm,
However, so how do patients feel about this? Well, if you look at the media, it looks like things are very negative.
mhm,
Annually, there's the GP patient survey that happens. patients registered with patients, a selection of patients are sent a survey to reflect on their experiences of their local of their registered GP practice. This is done annually. It has been done for years and years and years, so it provides a good piece of data to reflect on trends over time, for example, in how people are feeling about general practice and the services that they provide. It's really good. I'm sure we'll link in the show notes as well.
Hmm.
And you can look at your own local GP's data, the GP practice where you work. Practices are required to look at this on an annual basis and
Hmm.
reflect on it. Or you can look at national and regional data. So this is just cherry picking some questions and looking at the national data. So how satisfied are you with general practice appointment times that are available to you? And there is data from 2021. People do criticize this for having quite a low response rate from
Hmm.
patients. So it's by no means a perfect survey, but actually people are more satisfied now than they have been over the past 3 years, if you believe this data with appointment times that are available, and fewer people are dissatisfied than at any point in the last 3 years.
Hmm.
How often do you speak to your preferred GP when you would like to? So 45 compared to 50% in 2018,
Hmm.
not an enormous drop in terms of people's perceived access to their preferred GP. Really, it's a real shame that they changed this question so there isn't a comparable in previous years. It was, were you satisfied with the appointment you were offered? But 82% of people are satisfied with the appointment
Hmm.
that they've been offered. What type of appointment you get? I think we're planning on doing another episode on the GP survey to go
Yep.
more into this data and talk about whether it's still the best way of measuring people's experience in general practice, this paper-based survey. But it's just interesting to reflect. Yeah, okay, the pandemic came and there was a big increase of access on phone, a reduction in face-to-face appointments, and a small presence of video calls where previously no one was really reporting that they had a video call, and a reduction in home visits. Interesting. And then finally, during your last general practice appointment, did you have confidence and trust in the healthcare professional that you saw or spoke to? And this is holding sort of rock steady over time, with
Hmm.
very high levels of confidence in the person they spoke to. So public confidence appears to be holding up in general practice, which is perhaps, it's a positive. It doesn't mean we're not in crisis,
Hmm.
but it's a positive at least. And just to quickly talk about some other things which are potentially positive. So people say, yeah, you feel bad. Maybe you've just been through a really rough time with. I don't believe this, by the way. I'm sort of what do they call it? Straw manning an argument a little bit. They say, well, you've been through the pandemic crisis. It's been tough for everybody, but look at some of the positives that are there. So look at the 5-year um, contract negotiation that runs through to 2024, and actually there are annual uplifts in all of your main funding streams by 3% or in excess of 3%.
Hmm.
And at the time when that was negotiated, that was above inflation. Be interesting to see how inflation figures pan out over the next 3 years, given the amount of economic stimulus that's in place.
Hmm.
But that people will say was a positive. There are all sorts of kind of individual measures that were brought in the last few years to try and support general practice and support the partnership model. So there's £20,000 golden hello for new partners. I think, was that particularly focused on certain areas, or was it in general? I think there was some additional funding focused on attracting to underdoctored areas
Yeah.
as well.
Although it
Um,
was a national scheme,
yeah,
massively criticised because it didn't include practice managers. So I think that's one thing that's had a huge um, controversy, shall we say? Because
yeah.
although it looks at focusing on improving the partnership in general practice, it was very much prohibited from practice managers from being included, which is a real shame, to be honest, because I think we've lost the opportunity to have really qualified people join the partnership aspects of things and managing practices more effectively. A fair criticism I think that's being levelled at the organisations that derived this contract.
I think that's fair criticism. But the will was there to
Mhm.
attempt to help, and there was something behind that will. There are new resources through primary care networks, so that's been a big area where funding coming into primary care and resources into primary care has increased dramatically. Do you want to reflect on the scale of those resources, Gandhi?
I mean,
I
we're
don't know.
talking
Maybe
significant
some head.
potential funds, some networks are seeing from next year onwards, £1 million+ worth of resources to increase their staffing. I think the challenge we've seen with this, though, is that it's very restrictive in terms of how that funding and those resources can be used, and that's not just for staffing but for other areas. The paperwork and the bureaucracy attached to it is mind-boggling at times. And then the added challenge is actually finding these particular individuals has been a real challenge for several areas. And I've heard from many PCNs where they've said that, they've got potentially hundreds of £1,000s worth of allocated funding, but they just cannot find anybody because these people just do not exist. And actually, would it have been better if that funding had just been given to networks to use as they see fit to derive the staffing that they need? Would that not have been a better use rather than just saying, well, we've offered networks money and they've not used it, which is unfortunately what I think many people are expecting NHS England and the government to turn around and say to many of us in a couple of years' time.
Yes, and it allows them to pass the blame to primary care networks for not spending it when really they haven't planned the NHS workforce appropriately and made people available
Mhm.
and trained and in the right positions in the country to fill those roles. We'll see how that debate
Yep.
pans out in a few
And for
years.
clarity, for those that don't know about the funding, none of that funding has actually been available to spend on actually having more GPs and practices.
Yeah, you cannot spend the money on GPs or nurses
Mhm.
or healthcare assistants. Actually, it's for professions and allied health personnel that don't traditionally work in general practice in a sort of
Mhm.
historic sense. So, but all these things being said, actually, general practice, when compared to some of the other places you can work in the NHS, which, let's face it, are not having a great time of things either
True.
over the last year or few years. It is not that there is a sort of a beautiful rose garden where everyone wants to work in secondary care either. But at least in general practice, we can say, and I can say absolutely, it is a rewarding job. It is varied. Children, old people,
Mhm.
cradle to grave, full span of mental and physical health illnesses that you have contact with. It's a real honor to follow people, through their lives with continuity where we're still able to deliver it. And we can in many instances and many parts. You can follow those people through time and have a real relationship, with them in terms of being their doctor. It is portable. You can
Yep.
work in any city in the country. You will probably be able to choose to work or move anywhere in the country, possibly even the world. It is interesting. And actually, people have control of their working lives in a way that they don't in secondary care, in that
Mhm.
if you want to just work 2 days a week, it's very easy for you to do that. Obviously, you get 2 days a week income as a GP, and you might end up working a third day to catch up with the work that's undone in those 2 days. But you have control over how you work, and you can be a locum, you can be salaried, you can be a partner, and I think that's really, really good. And you can have a portfolio career, and you can do all sorts of other interesting things. So I think it's still actually a good choice. I think the system is really struggling, but for an
Mhm.
individual GP who retains the right attitude and the right control over their working life, it can still be a very rewarding career. What
Mhm.
say you, Gandhi?
I agree. I mean, we're still both practicing GPs. As far as I'm aware, we love the profession, the workload. I still enjoy, having my contacts with my patients. I still enjoy working my practice. I still enjoy everything that general practice offers. I think the challenges we face, and that we've talked about a lot of them, and still got more to discuss. But the key thing is that a lot of this is now down to system impact, and it's things that are in some ways beyond our control are having impact in the way that we can manage things. And if those things don't change, are we going to see a shift in how many view the profession? We are unfortunately seeing more and more people leave because of the difficulties, or like we talked about earlier, they're limiting the exposure they have. And therefore, that's why we're having less clinicians around to help out. And that's causing more strain on the system itself because then you've got less bums on seats, for lack of a better term.
And Roger's just made a good comment. Roger Boyle. Um, During my entire career, the government has always passed on blame rather than pass control. Um, I think here really.
Yeah.
I think we're going to come on to some of those things next, because I think one of the next things we were going to talk about was media reporting and the political situation.
Yeah.
So that's a nice segue in. Gani, how have you found the media reporting around general practice during this sort of period of COVID pandemic?
Yeah, it's been crap, in it. Let's be honest.
It's
The media hates general practice. Generally speaking, I think there are definitely pockets where they feel that that is an essential part of the healthcare system, but particularly some of the more prevalent and particularly right wing aspects of our media are always quick to lay blame on general practice and target us as much as possible with a negative tinted glasses, shall we say? And unfortunately, the public buy into that. And we've seen that with, the view that general practice has been shut for the past year and a half, and we absolutely categorically have not been. And yet that is still the prevailing view because that's the view the media wants to portray of general practice. And 18 months down the line, it's still a view that we can't get rid of because that's what the media says.
hmm, I think it's an easy, universally understood narrative for people that, and it's an experience many people share, that it can be tricky. It
Mhm,
can be hard. I mean, let's face it, because of the pressure general practices are under to get an appointment with a GP. But I
mhm,
think it's one of those appointments that's so universal. So my mum talks to me about this on the telephone,
mhm,
about that it's difficult to get into her GPs, and I'm sure my GP surgery is much better, but it's hard to get into her GP surgery,
mhm,
and it's been more difficult over the last year. It's just it's one of those experiences that is kind of universal, and there's fewer and fewer of those experiences in the country. So I think it's sort of almost irresistible, really, for journalism to get on that bandwagon. People are going to click those links and buy those newspapers and read
yeah,
about that story that actually sort of touches their life as well and want to know why that is. So I think it's almost sort of an inevitable kind of force that we're going to face these stories, unfortunately.
mhm,
I think it's what do we do about it? Can we change any of that equation? And if we can't, we just have to do our best to combat these stories and concentrate on the individual relationships that we have with our patients. Because my mum loves her GP at the end of the day, and actually she's
mhm,
always talking about, oh, Dr. Sanderson this, and I forget the names of the other ones, and oh, he's doing this now, and actually she really, the flip side of it's part of her community, and actually she loves talking about the GPs, and she really likes them. She just wants to see them. So um, I think it's complicated, isn't it? That relationship that people have with their GPs, and I'm not
mhm,
sure what happens in the media actually reflects what the public properly think about their GPs. Although I'm sure they universally think access is rubbish, and I'd
yeah,
love access to being included. But yeah, it's difficult. I think the issue I have is the effect that it has on the workforce, because it's really draining and damaging for people, particularly when people feel they're working hard and trying to do a really
yeah,
good job, and it's just a kick in the teeth. And I think it would be nice if the media recognized that, or at least tried to balance it with more positive stories. You always
mhm,
see lots of positive stories about the children's heart surgery unit. I'm sort of being a little bit patronizing with this now, but there are areas of medicine that it's easy to have good stories about. You
mhm,
hear some bad stories about children's heart surgery units as well, and we have done historically. But you know, you know what I mean. There are good news stories around these that are easier to tell than the bad news story around general practice access. Anyway, I'm going to stop
mhm.
harping on. Anything additional to say about media reporting, Andy?
I think until we see a change in the public advocacy of how the healthcare system works, I think unfortunately it's something that's not going to go away. You and I both know that healthcare is changing, that we are going to have increased number of additional roles where patients won't be seeing their GP. But that message needs to be communicated to the public because the public still have the expectation that I can see a GP however and whenever I want. Whereas actually we know that's not happening, but there's no public messaging to say that actually that's not going to be necessarily the case. It is. We are seeing the increase of additional roles. We are seeing the reduction of GPs being available. None of this has been communicated to the patients at all, and that public message needs to happen. And that's where the media controls a lot of this. And until the media are on board with sharing that message, we're going to have, unfortunately, I think, more conflicts coming through most of the practices. And that's a challenge that, unfortunately, I think we're all going to have to bear.
Hmm. Interesting comment just come through. It's
Okay.
upsetting when even your friends repost GP bashing articles. I want to be able to point them towards easily read, truthful articles about how it really is. So I really like this comment because
Mhm.
there's actually a solution suggested, or at least an action point. And I mean, even I know you yourself, Gandhi, have done videos trying to explain some of the
Mhm.
issues around access that people can point to. But of course, it's easier if it comes from a more authoritative
Yep.
source, isn't it? Like the RCGP or BMA or or other areas. And maybe that's something that actually could be put in place. Some high level advocacy for the situation in general
Mhm.
practice. Maybe that's something the next time we have contact with people in positions of power that we could ask for
Mhm.
potentially. I like that. Thank you very
Yeah,
much for the
I
comment.
agree. And if you want ILO, Claire, feel free to signpost them to some of our content because we talk about this on a regular basis. So yeah. Um,
And
I think that's a good point to talk about the political situation, though, because this is a key thing that drives a lot of the media attention in particular. And I know that we've always felt that the political situation focuses on access rather than on necessarily on quality. Would you agree with that, Andy?
yeah, I think there is currently, and it hasn't always been. I think there's currently an obsession with access, and I think it's politically sort of irresistible, really, to say we are going to improve access to GPs because it's all over the media. It's a very common experience, one of the few remaining common universal experiences in the UK that people's front door to the NHS is the GP, and people on average will need to see their GP 5 times a year or whatever it is
Mhm.
these days. So it's actually for most people, it's probably the most contact they have with something paid for by the government, or a government service is that contact with their GP. So it's politically irresistible to try and talk about improving that and improve. And there's an obsession with, I think, access above all else. Regardless of whether it's appropriate. People talk about diverting to other sources and so forth. And I'm sure technology will get better at helping that with time, directing to other sources of health. But I just think there's a political obsession with access and promising access and not backing that up with
Mhm.
with resources. And I think it's. I was about to say the word disgusting, but I don't like it when people say that. But it's just really, really playing a game with people politically, and I don't like it. And healthcare should not be a political football. Um,
Yeah. Fortunately, it's the most valuable one that they often tend to use, and that's a real challenge
mm,
for many people, patients in particular, because they're told one thing, but again, by the media, and in reality, it is a completely different aspect of things. The vaccination scheme is a great example of that. Patients often find out more about the vaccination scheme plans than we do through the media than we find out in terms of what we're meant to be doing and stuff. You brought up something
yeah.
interesting there, Andy. What is the NHS trilemma?
So this I like this trilemma argument. So I first heard it in relation to fast food, and they said, right, you can have a restaurant, okay, but the food can be cheap, or it can be good quality, or it can be quick, but it can never be all three of those. There's always a trade-off. If it's going to be quick and it's going to be good quality, then it'll probably have to be expensive. So there's this principle of trilemmas, and I think the same thing applies with kind of the NHS really, and actually it's probably universal with any service like fast food or providing healthcare. And I think the trouble is the government tries to have it all. So you
Mhm.
could have good universal access with really good quality care, but you probably can't do that at the same times as keeping costs as low as is absolutely possible. It just doesn't fit. You might have to resource it better, or you would have to resource it better to have those things. And I think the government just isn't honest about
Yep.
this. I think we should have more honest discussions about the affordability of good, accessible healthcare. We spend the lowest proportion of our GDP of. We looked at this, in the last episode, looking at the Commonwealth Institute report. We spend
Mm.
a lower proportion of our GDP compared to other developed countries on their health service, yet we promise so much politically,
Yep.
and it just doesn't add up. And I think we need more honesty from our politicians, although it's hard to see the political motivation for them to be more honest about it. Although maybe
Mhm.
someone should try. I don't
Mhm.
know anything else to say about this, Gandhi.
No, I think you've hit the description quite clearly. You can't have all three of these things effectively. It just doesn't happen, and particularly on a resource that you're then providing for free. I'm afraid. If you look at private healthcare may give you amazing care, but it will cost you, and you can have that when you want in terms of access and stuff. Um, that doesn't work necessarily in general practice, because there are aspects of waiting lists and that kind of stuff. Those are things that are not going to go away. And if you try and determine it based on need, me and you have both seen this. The moment you classify something as urgent, well, how does that compare to the urgency of everything else? And that's what we're then being told by other places to say, well, if you need something, have it badged as urgent. But then if everything's urgent, then nothing is urgent. So how does that work?
Yeah. Roger's just jumped in to say the NHS isn't free, and absolutely right. Paid for by taxation.
Absolutely.
Absolutely. So it's not free, although it almost feels like a freebie from the government, doesn't it, when they promise more without paying for more healthcare?
Mhm.
It's complicated, but agree entirely, Roger. And then Prakash has made a comment as well. I'm just reading through. Shall I read? Sadly, it can only come from practices to engage with their patients more differently. Tell them what they do, and as I do now at my practice, inform them of your activity and bang the positive drum. That's the only way to rebalance the otherwise incredibly negative narrative from the media. Here.
Mhm.
Absolutely. Yeah, I think it's right. It's about that individual relationship, which I think is still really strong
True.
with patients. So I think that's the leverage that we've got, and we need to preserve that and build on it.
Mhm.
Absolutely.
And if people want guides on how to do that, we provide that both at EGP Learning, as well as another organisation I'd recommend people have a look at is Redmore Health, because they've been doing loads of cool things around this stuff in terms of helping patients, practices advocate appropriate information to their patients.
We were going to talk about workforce next, Gandhi. I'm
Mhm.
gonna I'm gonna put it out there that we've talked about workforce a lot in and
True.
amongst the other points that we've made, and we talked a lot about problems with the partnership model last week. So, uh, have we covered workforce? Do you think?
I think we've covered a fair amount of it, and if not, we've got various other streams that people can have a look at in terms of the differences between the types of roles in general practice. So generally split into the three aspects of partnership, salaried, and locums, and then there's the additional roles. And as we mentioned earlier, that the additional roles, whilst there may be a workforce support, it's not GP, and the expectation of a patient to always see their GP is not something that's going to be valid.
Mm. Actually, I'm going to throw something in. So, Gandhi, why it strikes me that if we just had more GPs, then the
Mhm.
existing GPs wouldn't feel as stretched. They could maybe even work more hours, more days of the week themselves, and not feel that they have to hide under the blanket, one day a week. Not that we're
Mhm.
doing that, but that they have to take a day a week off from work to catch up with the paperwork, that they do now.
Mhm.
If we just trained and employed more GPs as a country, um, why can't we do that?
'Cause it costs more.
Yeah, because it costs more. I mean, obviously, but it's just, you know,
Let's be
other
honest,
countries.
it costs
oth
more. If you want more GPs, you have to pay more money, and the government doesn't want to pay more money.
Yeah, well, see, other countries do have more GPs, more
Mhm.
primary care physicians per head of population than we do, and they have longer appointments. They see a few people a day, but concentrate on those patients more. It is possible. Other countries do it. I think the government doesn't want to pay, and I suppose ultimately they don't want to raise taxes to pay
Mhm.
for it. But it's just an interesting question. One wonders, if the current model of paying for healthcare is sustainable. Maybe that's a question for the "Is the NHS in Crisis" episode
Mhm.
that we may do in the future. Um,
Absolutely.
this next one was, I think, controversial for us in a way. So, technology. What role does technology play? Because I'm developing a sense that I think that technology can make things worse. And I didn't think this a few years ago, but um, people often talk about the additional technology we use, such as electronic consultations, and I think that's the main one, really. But also,
Mhm.
email and people being able to text their GPs information, and that actually all this does is it just adds additional lanes to the motorway that all lead to the same place where there aren't any more GPs or people actually to process all of this stuff. And that what technology isn't doing yet is actually affecting productivity or improving productivity. It's just improving access to a still limited resource. And I'm increasingly believing that this is part of the problem now, I think.
Mhm.
But what say you to that, Gandhi?
I think technology makes general practice different. The perspective whether it's better or worse, I think it's based on your experiences and your capabilities. So, has it improved access, generally speaking, for the tech literate working able? Absolutely. Has it improved access for the elderly patient that doesn't know how to open a web browser? Probably not. So,
Further, reduced access for that person because that GP is wading
mm,
through all their e-consults.
having said that,
And
if you structure it properly, does that mean that practices can divert their resources to deal with the different lanes more effectively? That was the hope. That was the plan. The problem is you kind of chuck a pandemic onto that. You chuck onto, various different aspects, including providing a well-beating vaccination program and, supervision of different roles, additional, bureaucracy in terms of everything else you have to do on top of that. That's why we're not seeing that change happen, because everybody's too busy trying to do everything else that we've been told we have to do, as well as everything that the media and the politicians suddenly decide to add in, such as, for example, Priti Patel now saying that GPs will be signing off people for their gun licenses because of recent unfortunate events that happened in Plymouth. You know, those things don't help when you add everything into the risk sink of general practice. So, if you want it to work, and I think genuinely think it can work, technology can help improve general practice. And we've seen really good test cases where that does happen. It only happens where you've got effective system change that makes it happen. And important to remember, the technology is not the answer to every patient. That's the key part.
I I don't now believe that's always the place. I think there are places
Mhm,
where um, the circumstances exist that some of the technologies, the way they are existingly designed, work.
mhm,
But I don't think that those circumstances exist everywhere. And I think in some of
true.
the places, it makes the problem worse.
Mhm,
But yeah, it's all about the implementation and the process. And I think the point I'm making is I think technology has done a lot to improve access and make it easy to send some information to your GP for them to process. And actually, that's
mhm.
that's that's really really easy. I mean, that's not much of a technological challenge at all.
No.
What it now needs to do is actually focus on the clinician side and actually help us process that information more effectively and be more productive. And I'd like to see more focus on technology to help people be more productive in their jobs rather than just add another lane to the motorway.
Mhm,
Yeah, interesting comment there. We've had a few comments come through again. Roger's with us for the whole episode. Thanks, Roger. Patient contact with pharmacists, etc., seem to generate more problems sometimes. They seem to have very defined numbers of patients they see, and if they can't be seen by them, I think, then the work appears to be offloaded back to the GPs.
mhm.
Um, I think we see things like that happening. Um, not
And general
always, but we do.
practice is the risk sink of everybody else.
Yeah, it all comes back to the GP, doesn't it?
Mhm,
GPs always had to sign gun licenses. What Mrs. Patel suggested was face-to-face contact with GPs. Yeah, I mean, it's almost an episode in itself, isn't it? I mean, I think we used to confirm that they had an absence of certain problems
mhm,
and then more recently we were asked a question that was worded a bit like a judgment in terms of will be aware of any reason why we would be concerned or something.
mhm,
um and I'm not familiar with what she's now suggesting we do, but I suggest the implication will be an additional amount of responsibility taken by the GPs
yeah.
for
Let's be clear,
saying they're
GPs
okay to have.
cannot prove you to have a gun license. We are not involved in that process in that way, and it is the realm of the police to determine whether or not you need a gun license or not. GPs are simply being asked to provide medical information, which we can provide, but we cannot certify that someone is safe to have a gun. If that's what, in any way, shape, or form, somebody's asking a GP to do, the answer should always be, "I'm not qualified to make that decision," because we are not qualified to make that
Mm,
decision. Let's be absolutely clear on that point. It is not a GP's role to certify
mm,
someone to have a guns license.
yeah.
And simply put, if that was to come to us, the answer would always be no, to be honest. I'm not prepared and not qualified to make that decision.
And the one of the last things we were going to talk about was funding as
Mhm,
well, because I often think, and again, this is just dreaming because it'll never happen. But if we moved from a block contracting model where GP practices are paid a block amount of money to provide actually almost, well, unlimited access to their service for the population they serve for a fixed fee, if we were to move, and I think that's where a lot of the problems lie, because that fixed fee doesn't increase at the same rate as the complexity of the patients and the
Mhm.
demand, and that's why people feel that access is worse, and it is worse than it was
Mhm.
a few years ago. I think it's my personal experience, um, and that's because the the promises the government make can, drive and change and shift demand, but the funding settlements are always separate in terms of how much resources goes into that because of the nature of the block contract. And if we just moved away from that and had a system where actually funding follows activity, and if somebody has an appointment with their GP, the government pays on an appointment by appointment basis
Mhm.
from general practice. What that would mean is that the workforce and the available time to do the job properly can genuinely flex up and down with the demand. Um, and I'm sure we'd quarrel about the amount they're paying for what they're getting and so forth, but it just strikes me that that might be a more sensible way to run a system, and many other health systems in the country work on that
Mhm.
model of purchasing activity. They're generally more expensive, um, but where that money is paid for them to have care, often people are very satisfied in the outcomes for those people where the money is paid by themselves or by the government are quite good. Um, I don't know. You got any thoughts on that, Gandhi?
I think you're opening Pandora's box with that postulation, which it's about time. And I agree. I think it's time that we open that debate. How do we want our healthcare system to be funded? The NHS is often badged as one of the most amazing healthcare systems in the world. Well, we found out in our last episode that that's no longer the case. Unfortunately, the
Yeah,
NHS.
but A&E are paid by activity. Why not
Mhm.
GP? It
Agreed.
doesn't it doesn't it doesn't mean destroying the NHS or reducing free at point of service or
Mhm.
government funded socialized healthcare. It would probably be more expensive. But it doesn't mean getting rid of that. And it's just sort of parity with other parts of the NHS that get paid by activity. I'm not sure it's that controversial, but
Mm.
equally on the other
Well,
side of my
like
face,
you
I know
say,
it's
it would
controversial.
massively impact the funding and the available resource that it currently exists. If you look at the PSSRU, which I can't quite remember what it stands for at this moment in time, but they're one of the organizations that have done some calculations to work out how much an appointment with your GP costs. I think many people will be surprised that across the nation, an average appointment with a general practitioner costs the system. So this is not individual GPs. I mean, it's very clear your GP does not charge this to the NHS. This is what the estimated cost of having a 10-minute GP appointment is. If I remember rightly, something like £33 for 10 minutes with your GP. So if you work out the basis that most practices are paid according to the GMS rate, £97, am I right, Andy? Something like that.
Yeah, you get some
£97 a
quaff money on
year.
top of that. I think, is it
Yeah,
on average about 150, £160 per patient you probably get.
£150, let's call it, when you include everything, that equates to just under 5 appointments per year a patient is able to be costed to have with their GP. And I can think of a majority of my patients that I see on a regular basis that absolutely dwarf that number in terms of the aspects and use. Is that right or wrong? That's not the patient's decision to make. This is how it's funded from a system perspective, but that's what the current workload is and how it is funded, and the reality is it doesn't work.
Mm.
So do we need to have that debate? Absolutely. Will we have that debate? Probably not, because it's in the government's best interest not to.
Probably, yeah. Continue to dump on GPs instead. That's the way to
Mhm.
do it. Prakesh was just reminding us that there's probably a move. There's probably going to be there's motivation to move secondary care to a block contracting type model as well because of how great a deal it is for the government when it comes to primary care. I suspect.
And the
But
challenge with that is then we see that increase in restrictions of what those, services will see and do, which is actually the way that block contracts are then handled. So,
yeah.
again, locally, if I try to refer a patient to a podiatry service, it's pretty much trying to beat Usain Bolt in a race, to be honest. It's not gonna happen because of the
Well, it's
charge.
only if they include unlimited access
Mhm,
in the terms, but it's going to be difficult to get that through.
mhm,
Yeah, Louise Robson just agreeing that general practice dumping ground from government to secondary care. Everyone dumps around on GPs. Yeah, it does feel that way. We've
mhm,
drifted back towards the negativity a little bit. And then Roger was making a point about going back to the 1960s, Red Book. There was item service component, possibility to be game playing. Yeah, and I think that's why people are scared. The government often, when you talk to people who work in NHS England,
mhm,
there's a concern about wastage of money if it's given without strings attached to primary care. And I think in some ways we need to get over that. And I think as we get to
mhm.
larger, better run primary care organizations, which I think is the direction of travel, I think we hopefully there will be more trust from the Department of Health. Hopefully.
Mhm.
Yeah. So Gandhi, what's your verdict? We asked the question, is general practice in crisis? What's your verdict?
I'm gonna go to you first, Andy.
Me.
Mhm.
I liked the point someone made right at the beginning in our comments. And they said, no, crisis is an acute thing. And this has been going on for years. General practice is chronically ill, I think was the implication of
Yep.
that.
Yep. So the
Um,
comment, we don't know who by, unfortunately, because they haven't authorized StreamYard, but that's fine. The simple answer is no, because a crisis implies that the problem is acute, and this has been bad for years.
yeah, I'm gonna. It's a bit of a cop out. I'm gonna say I think I think general practice is chronically unwell. Um, it's multi-morbid. There are many problems, and I think it needs a lot of work to patch it up, and it needs a little bit of TLC, tender loving care, from the media and the government as well. I don't think it's as easy to solve as a crisis is easy to solve. Actually, I think that the problem is more complicated, but we're going to have to solve it. I would separate that from the career as a GP, because I think actually, if you get your career right and you structure your career right, I think you
Mhm.
can still have a good career as a GP. With it's going to be problematic. It's going to be stressful. I mean, it's that type of job, but you can have a rewarding career as a GP within that chronically unwell system. The two things are different, but is general practice a system in crisis? It's chronically ill and it needs a lot of input, I think. Gandhi, what do you think?
I think crisis is probably what we're heading towards, to be honest. And the question is, what is going to be that tipping point? Is the blood bottle issue that we talked about earlier at the stage going to be the thing that sets off the NHS down a path that means it's just going to capitulate? I think general practice is going to face the brunt of that, unfortunately. So, again, for those that don't know, there is a massive shortage pending of blood bottles. So, in terms of patients having blood tests taken, that's going to impact acute and chronic care for all patients across the NHS. And that's the thing that's going to impact every part of the NHS, general practice, hospitals, that kind of stuff. And is that going to be the thing that actually pushes the crisis that we've been bumbling along in the past few years over the edge? Possibly. When you combine that with we're about to head into winter stages, when you combine that with everything else that we know is coming in the next few weeks and months that would normally happen to a health service under stress. And let's not forget, we are a tired workforce. Trying to find staff to cover workload is just unbelievably difficult. I'll share my personal story. I've been on leave for the past 2 weeks. I've still had to help out at the practice despite being on holiday. I wasn't really a holiday. I was just not in the practice. Still had to dial in to help out because we were that short staffed, and that's not seen by other people. And that's the way the situation is. I think there's many other stories and many other practitioners who are exactly in the same situation. And how much longer can we carry on? If we're not in crisis now, I'm going to guarantee it's not going to take much more to push us over to the point where it just stops.
So, if you're a medical student or you're a foundation year doctor
Yeah.
deciding on what career to embark on in the NHS, then come and join us in general practice. Okay. I would say,
I'd
I think
agree with you there, Andy. The difference is it's not is being a GP the worst thing in the world and the crisis point? Absolutely not. The profession itself is still. I'm still a GP. I'm still going to be a GP. I still want to be a GP. Is the current system? It just needs change. It needs something to help it along. And I guess this is my plea to those far above us in terms of what they do and how they structure the healthcare service. Things need to change, otherwise it's going to get worse. But
yeah,
yeah.
the patients suffer more than the GPs in the end, although there are a
Mhm.
lot of individual GPs and groups of GPs who are suffering, so we have to acknowledge that too. So we've overran a little bit on
Mhm.
our normal hour, but it's been a very lively discussion. It's been great to have lots of comments from people out there watching us on a
Agreed.
number of different platforms.
Mhm.
It's been fantastic.
And absolutely, if you do have any further comments or questions, let us know. We'd love to see, hear them, and everything else in terms of what you're thinking about this particular episode, and more importantly, our future ones that we'll be covering, including looking at the GP survey, as well as other aspects of the healthcare service, and as always, trying to tech enhance your primary care and learning in whichever way we can. If you would like to check out more of that content, it's coming up right here somewhere, and I'm sure YouTube's recommending another video for you right underneath. And as always, we are here to help tech enhance your primary care and learning. We'll catch you in the next episode.